Information concerning health and health issues to put you in control of your life and to give you information that will enable you to take full control of your health, because your health is your wealth. I am Errol Griffiths, co-host with Pauline Byers, and we have tonight with us a physician by the name of Lola. She will be our guest for tonight. We thank the Lord for her. And once again, you are watching Liberty Hour, and thank you for tuning in. Over to you, Pauline.
Hello again. We're on the long week last week dealt with diabetes, and we had quite an interesting time discussing what diabetes is. So tonight we'll be looking at sickle cell thalassemia, what that really is, and how it impacts on people's lives, and how people can best manage the condition. And we have with us tonight Dr. Lola, who comes from a nursing background, and she spent many, many years working with sickle cell sufferers and their families in the UK. So welcome, Lola.
Thank you.
Thank you. Now, I know that you've been working with sickle cell for a number of years. How many years exactly have you been working?
Well, that would be telling. It's probably coming up to about 25, 30 years now. So quite a long time. Yes. Yes, it is.
I think your work and your experience has impacted the world of sickle cell suffering quite a lot in the UK. You were there at the beginning when the service was being developed.
Well, I was near the beginning, but not at the very beginning, because other people were pioneers in terms of sickle cell. So people like Elizabeth, I don't know, were the pioneers of sickle in the the late 70s, before I came on board, sort of like early 80s.
Yeah, so what exactly is sickle cell anemia?
Sickle cell is a collective name for a number of conditions. Sickle cell anemia is just one of those conditions, and they're all called together, they're all called sickle cell disease. And they're all genetic conditions that affect the part of the blood that carries the air that we breathe in into our body, the part that carries it around the body that is affected. So it's a condition that affects a whole range of people that is to do with genetics. So in other words, you have to inherit it. In the same way that you inherit the color of your skin, the shape of your nose, or even be tall, even be short, you inherit the type of hemoglobin that you have from your parents.
Right, you've used some words there that, so some of our listeners might use genetic, inherited hemoglobin.
Okay. Let's trace it all back a little bit. Let's trace it all back a little bit. First of all, let's start with the mother and the father.
Yeah.
We all know when you're born, when a baby is born, everybody says, oh, he looks like mom, oh, he looks like dad. That's because they have the blueprint to determine how their baby will turn out. So in other words, their genes is what determines how their baby will turn out. So if you've got, for example, a black couple, you wouldn't expect them to have a white baby because they do not have the genes to make a white baby. They have the genes to make a black baby. So similarly, all our makeup, the things that make up our bodies, are all controlled by these genes. So the genes are what we call the blueprint to determine exactly how you turn out. Are you with me? So for example, when I was born, somebody said, oh, she looks like the mother. Yeah? Now, if my parents are both black and they had a white child, I think my father would be a little bit worried because he'd be wondering what happened there. So similarly, precisely. So similarly, the type of makeup that you have in your blood is also determined by your genes.
So your hemoglobin, the red part of your blood, just as how you inherit the color of your eyes and your skin color, you inherit the type of red
blood cell that you have.
Right.
So you know, some of us black women, when we go to the hairdressers, we get our, we get the roots relaxed and so forth. That's because after 3 months, you find you have to go back to the hairdressers again. That's because your gene says you can only make curly hair.
Right.
So the same thing with your hemoglobin, with your red blood cell hemoglobin. When you cut yourself, all that red stuff that you see in your body is the whole blood. Inside that whole blood there are little different parts to it. And the main part that we're talking about tonight is the part we call the red blood cell. Now that red blood cell is like a bag. And inside that bag, it's got little bubbles. And those little bubbles are what we call hemoglobin. So those hemoglobin are what, when you breathe into your nose and your mouth, into your lungs, you get air into your body. But that air has to get from your lungs to all the different parts of your body. Otherwise, you won't be able to live.
Okay.
So what happens is your blood occasionally passes through the lungs, picks up the oxygen from the lungs, takes it to all the body tissue, including your fingers, your toes, and your brain, and every part, and gives away that oxygen so that they can live. Now, if I was to cover somebody's mouth and nose, after about 5-10 minutes, they will actually die because they're not getting oxygen. So the job of this red blood cell is to carry hemoglobin. And by carrying that hemoglobin inside it, it takes it around the body. And it gives it away to the body for it to be able to live and to function.
Okay, so what you're saying is then that some people inherit sickle cell hemoglobin, while others may inherit normal hemoglobin.
That's right.
So people with normal hemoglobin, can they ever develop sickle cell hemoglobin?
In the same way that I've been born as a black woman, I can't change the color of my skin. So whatever you've been born with is what you will always have. So, in other words, everybody inherits one hemoglobin from their mother or one hemoglobin from their father. If the person has inherited two normal, usual hemoglobins, they're the ones we say have hemoglobin AA.
And that is normal.
And that is the normal combination.
Okay.
Now, particularly for the sake of the men that are watching, it's very important to recognize that a child cannot inherit only their hemoglobin from their mother. Because sometimes, unfortunately, the men, when they come along and we say to them their child has got sickle cell disease, they'll say, oh yes, it must be from her side of the family. That cannot happen.
You need to get it from
You need to get it from both, from a man and from a woman. So you need to get it from your father and your mother in order for you to have sickle cell disease.
So does that mean that the sickle cell, the hemoglobin S, is coming from the male?
It's coming from both.
Okay.
If a person has, as I said earlier on, if you have normal hemoglobin AA, there's no unusual hemoglobin there. And that person has the most common type. And that type can carry oxygen very well. Yes, it can function very well. It doesn't have a problem. Now, some people will inherit a normal hemoglobin 1A from one of their parents and a sickle hemoglobin from the other. These are the people which they have sickle cell trait.
So they're carriers.
They're the carriers.
They're like bags, so they're just carrying it.
They're just carrying that unusual gene, that unusual hemoglobin gene. But it's important to say, those individuals are perfectly healthy.
So the carriers can just have it but not affected by it?
They can just carry the unusual gene but not be affected.
Well.
They're perfectly healthy. That's why we call them healthy carriers.
Right. So the people then with sickle cell anemia are the ones that inherit hemoglobin S from mom and hemoglobin S from dad. And instead of having AA, they have SS.
That's right.
Okay.
That's right.
Right. So how would a person know? And but before we go there, who is mainly affected by sickle cell anemia?
It's primarily people that sub-Saharan Africa, people from the Mediterranean, people from Asia, all can inherit these unusual hemoglobins. Those are the populations where it's most common. Now, the Caribbean is because the people from the other parts of that world, from Africa and so forth, have traveled to the Caribbean, and therefore you see it predominantly also in people from the Caribbean. So people from sub-Saharan Africa, Asia, and the Mediterranean islands, they're the people you see most commonly in. But it's important to mention that though we're talking about sickle cell is only one out of about 1,200 unusual hemoglobins. Yes?
Yes, when I was in that world, it was 700.
No, it's gone up.
Doubled in two.
We keep finding new ones, and we keep naming them, and so they're quite fascinating.
So when we say hemoglobin, just so that someone, layperson, would understand, you're talking about the blood system.
Yes, we're talking about the blood. We're talking about when you cut yourself, that red stuff that you see contains hemoglobin inside the red blood cell. And it's important for keeping you alive. If you don't have hemoglobin, you can't live. Because you can't carry oxygen.
So Lola, tell me, would it worthwhile for someone who is of that origin Origin, for instance, Mediterranean, Greece, Turkey, India, the Arabian Peninsula, Spain, Caribbean, and part of the Americas. Would it be worthwhile these people testing their blood to see if they're carriers of this?
Yes. I think the important thing to remember is that, remember I said people with sickle cell trait are healthy carriers. Now, healthy carriers mean they will not know that they have that unusual hemoglobin. So in other words, they will not know they're AF, because unless they have been tested, then they will not know they're carrying. So that's why you find quite a number of people that say, but I'm perfectly healthy. Or when I was born, I was a big baby. You know, I was 3 kilos, I was 4 kilos. You know, I've not had any problems. I've never been in hospital. I've never been sick. And you have to explain to them that if you're a carrier of an unusual hemoglobin, you will not have symptoms. You will not have any signs that you're carrying an unusual hemoglobin.
Okay. So, if then a child is born with hemoglobin S from both parents,
Right.
What problems does that child face?
Okay. When a child has got 2 hemoglobin S, we say that child has got sickle cell anemia. Now, sickle cell anemia is one of the range of conditions that we call sickle cell disease. But sickle cell anemia, unfortunately, is the most common, and it's also the one that tends to give rise to the most symptoms. So what happens, if you've got normal red blood cells, your red blood cells are round, they're soft, they're very spongy, they're very pliable. So when they have to pass through the veins, you know, these are the network that you see on your hand. When they have to pass through the veins, they pass through the veins very easily because they're soft and spongy, bendable. So even if they have to pass through very tiny, tiny blood vessels, you know, they can squeeze through and they'll still retain their normal round shape. When you've got sickle cell anemia or sickle cell diseases, what happens is that the red blood cell becomes like a half moon shape, like a banana shape. Once it becomes that shape, it becomes hard, brittle, and it's very fragile. So those red blood cells can't carry oxygen very well. And as they try to pass through the blood vessels, they're not able to maneuver through the blood vessels because they're so rigid.
In other words, they've lost their dexterity.
They've lost their ability to be soft and spongy.
Okay.
So they're hard and brittle. Now, if you imagine trying to pass an orange through a stocking, it'll fall through because it's still round and what have you. Now, you imagine trying to pass a banana through a stocking. You know, it would have difficulty because it's hard, because it's got a funny shape.
You get like a traffic
jam
syndrome when you get several blood cells trying to get through at the same time.
Would this then be at the point when the symptoms begin to appear?
That's right. People will have occasions where you get a lot of these red blood cells trying to pass through a blood vessel. And as they try to pass through, because of their shape, they can hook up. And as they hook up, they cause a traffic jam. Wherever they cause a traffic jam, the blood cannot flow through beyond that point. It's just the same as, you get on the M1, where you've got, one car that hits another one, then the others come along, and they can't get through. And others come along, they can't get through, and you get a whole pile of them. And what happens to all the traffic coming behind? They can't go through. So that's when you get it on the radio that the M1 is absolutely obstructed. So the same thing you get with this. When these red blood cells, when they assume that sickle, that half moon shape, they can't get through the blood vessel, they cause a traffic jam. Which means blood cannot go beyond the point where the blockage is. If you can't get blood beyond that point, you can't get oxygen to that part of the body. If you can't get oxygen to that part of the body, you will get pain. And that's what we call a sickle cell crisis.
Tonight, ladies and gentlemen, we're looking at sickle cell anemia. Feel free to call in and ask a question if you want to about sickle cell anemia. Going on from there then. So then, you've got this traffic jam situation, you've got blood not being able to get beyond that point. What does it look like on the outside then for the person?
Well, I think this is the difficulty that a lot of our patients have, in that because it's all happening inside, it's quite difficult for somebody to believe them that they are in severe pain. You know, if you've got a wound and somebody can see that wound, they'll know that that is painful. But if something is inside you that is causing a blockage, that is not allowing things to get through, then, you know, nobody can see that. But what they will see is that you're in excruciating pain. You know, your face will be, you know, show that you're in pain. You will feel the pain in such a way you may be sweating, you know, because the pain is so severe. The person may be very sweaty, very agitated, and feel unable to concentrate and do whatever it is they need to do.
Sometimes, though, I mean, I don't know whether in all societies babies are checked at birth. But I know Errol spoke earlier about areas of the world that sickle cell disease is where, you know, sickle cell disease is prevalent. We know that Africa is one of those countries that are affected. In the UK, people are affected. And there are screening programs in different areas. But how would you know if a child under one who can't speak, who can't articulate the pain, how would you know that they were suffering?
Well, like I always say to a lot of my mothers, because parents worry that, you know, even when we tell them that the child has got sickle cell disease, you know, and then they worry about, will I be able to tell if the child is in pain? And I always say to the mothers, you know when your child is in pain, because you get to know your child better than anyone else. Most mothers will tell you, oh, that's I'm wet pain, that means check my nappy. Oh, that cry means I'm hungry. You know, so similarly, if that child is in pain, most mothers know their child is in pain. So what will tend to happen, the most common symptom or the first early sign that a parent may see is sometimes what we call a hand-foot syndrome. So for example, the child may have a swollen hand, or a swollen digit, maybe just one or two fingers, or a swollen foot, maybe just one or two toes. It'll be hot, it'll be very shiny, it'll be swollen, hot to the touch, and that's what we call hand-foot syndrome. And often, those are the first signs that parents will get that the child, you know, has got sickle cell. So quite often, in fact, we used to say in the old days, if any black child comes into hospital with swollen digit and you've ruled out child abuse, there's nothing else that causes that other than sickle. So that should alert the health professionals if they see a child with swollen hand and feet, and you've ruled out that the child hasn't been abused, then you can bet it's more likely that child has got sickle cell.
Could the parents begin to look for something like a discoloration of the skin?
Well, the discoloration of the skin doesn't always happen.
Like in the yellow?
They may get yellow, but yellowing tends to happen only when they've had quite extensive breakdown of red blood cells. But that will not always happen. So you may not see that. In fact, majority of our patients, you don't see yellowing. You don't see, that's what we call jaundice. So majority of people are not actually jaundice. You'll walk past many people in the streets who have sickle cell disease, but you will not know they've got sickle cell disease. Now, in some parts of the world, that you see jaundice more commonly. Areas particularly where they have more breakdown of their red blood cells or they don't get access to very good care, then you may see that.
So this is in the yellowing of the eyes.
You do with some people, but not particularly in the UK. I see that more because I also travel to Africa quite a bit, and I see that more commonly when I travel to Africa amongst the patients in Africa, because I do go to Nigeria and other places, and I see the yellowing of the eyes more commonly there. But certainly in the UK, you don't see it as much.
Okay. You said earlier that, you know, the hemoglobin is passed on from parents. And we in the UK live in a multicultural society. And I'm wondering, to what extent has there been a drift, or have there been a mixed genetic pool of sickle cell, the sickle cell gene, amongst the host communities as opposed to the African, Caribbean, or Mediterranean communities?
Well, you're right, as you rightly said. You know, we're a multicultural society. You don't know who somebody's going to fall in love with, do you? You know, it's a matter of, you know, that nice young Jamaican boy down the road falls in love with that nice English girl down the road. And therefore, you will get intermixing of the gene, what we call the gene pool.
So it's nothing to do with skin color?
It's nothing to do with the color of the skin, it's to do with your genetics. Now, for example, in our area in Northwest 10, you know, where we've been testing babies since 1979, we get pockets of white, Caucasian, English people that have sickle cell traits. And then they usually say to me when I counsel them, when I give them information, they usually say to me, but I thought that's in the black population. Where did that come from? And usually my response to that is, you can't ask me. You need to ask your great-great-grandfather that. You see what I mean? Because, it's not something, the body is not an exact science, in that once you start intermarrying, then you'll find maybe 2 or 3 generations down the road, you forget you've got that Ghanaian great-grandmother, or you forget you've got that Indian great-great-great-grandmother. Remember, the British colonized a large population of the world. We could be India, we colonized Africa, Asia, right. So, and of course, they intermarried. Precisely, it's widely. So, Sickle, you will see it in these populations. Also, the one that I find most fascinating that we see, the one English population is hemoglobin C, D, and E. And those, the C, is more common in Ghanaians. Now, why would you see so much C in the white population? Do you remember the Ivory Coast and all that? The colonization, trading in gold along the Ivory Coast, etc. That's how that came about.
So C, D, and E is just they're just other hemoglobin traits.
Other unusual hemoglobin.
That people carry and are quite
until it meets with something else.
Until it meets S.
Yeah.
And activates it anymore. You are watching Liberty Hour. This is a health-based program that is coming to you every week at the same time, 6 p.m. until 7 p.m. live. We do open the lines so that our callers can call us and share with us their concerns. We'll be opening the line shortly so that you'll be able to speak to Lola, who is a doctor, a healthcare and official, and will be able to give you some guidelines, directions, and directives that will be beneficial to you. So, this week we are dealing with sickle cell anemia. We have dealt with healthcare with all types of healthcare issues over the weeks previous. We have dealt with mental health. We have dealt with diabetes. And we will still be coming back to diabetes because, as Pauline rightly calls it, it is the mother of all illness. So we still have a number of other health issues to come. But tonight we are dealing with sickle cell. It is a blood-related disease, and it affects a lot of the community, especially 1 in 500 Afro-Caribbean or Afro-American. If you are suffering from it, the numbers are on the screen. Give us a call and let us discuss it with you and give you some health information.
Yeah, it does affect quite a number of, the percentage was 1 in 10.
Yes, when we talk about 1 in 10, when we're looking at the prevalence or how common it is, it depends on which population you're looking at. So, for example, the high population, the epicenter for sickle is actually West Africa. So you'll find a quarter of that population, 1 in 4 people from West Africa have sickle cell traits. So it's very high. So, for example, in Nigeria, where you've got 160 million people, a quarter of them are carriers of sickle. It's less so in the Caribbean. It's 1 in 10 Caribbeans have sickle cell traits.
So how do I maximize health then if I happen to have sickle cell anemia? What's the best thing for me to do? I can say that I'm going to be cured. God's going to heal me.
Well, I'm a Christian myself, and I do believe in the power of prayer. Knowledge. God has used people like myself, people like with my colleagues that are doctors, people that are doing research into sickle cell. God has given them the knowledge to be able to care for those individuals. So, even though people will have the belief that, but until they are cured, until they have measures and evidence of that, I would suggest to continue to get medical care. And that is very, very important, because that's one of the things I was going to discuss with my brother here, in that some of the issues we've been dealing with in my work are where you diagnose a child with sickle cell disease, and the parents say, well, I've taken the child to church, and the church has told me the child is cured, so therefore I'm no longer going to give the child medication. And that is a problem, because we have had a number of children who, as a result of that song, have actually died. Because parents don't recognize that the Lord uses different people to bring relief from pain. And therefore, they must make sure that they continue to give their child the daily medication that's been prescribed. Because here in the UK, because I know that, the program is watched, all over the world. Here in the UK, when a child is diagnosed with sickle cell disease, the child is given prophylactic penicillin, which the child needs to take daily. Now, if they don't take that penicillin daily, the child is open to infection. One of the biggest problems that children with sickle cell and adults with sickle cell disease have is they can't fight infection very well. So as a result of that, that's one of the major causes of death, is infection. For example, I'll give you a few statistics. In Nigeria alone, we have roughly about 150,000 babies born every year with sickle cell disease. 160,000, that's a lot. And that's a lot. In England, we have roughly 300. Yet in England, we test every single baby that is born in England for sickle. In Nigeria, we don't yet do any testing.
So there should be a move, really,
towards
universal
newborn babies.
So that the children can get better.
Precisely. Now, the reason that those 150,000 babies that are born every year, 80% of them die before they're 5. And that's because they're not diagnosed. And that's because they're not given treatment. Because if the parents don't know the child has got sickle cell disease, when the child is not well, they will not know they need medical help.
How expensive is the testing then for sickle cell anemia in places like Nigeria?
Well, for Nigeria, a lot of it will have to be privately done. That's the unfortunate thing. Here in the UK, that's why I say in the UK we don't have an excuse, because you can walk into any out of like 30 or 40 sickle cell centres in the UK and ask to be tested totally free. You can go to your GP and ask to be tested totally free. Are you with me? But obviously, in other parts of the world, people will need to go and get tested and pay for it. But the fortunate thing, for example, in Nigeria, they've now established a sickle cell centre. Beautiful place, huge. But the unfortunate thing is they don't have the funds to equip it. They've built the building is there, but they're desperate for funding to equip it. So until they're able to do that, people will be having difficulty getting tested. Getting tested, but can I just say one thing about it, particularly in Africa? Getting tested by a reputable place or lab is crucial. I often get people who come here and they're pregnant, and we test them, and we find they've got sickle cell traits. And they say to you, but I was tested back home, and I was told I was okay. Yeah? And now we're telling them they've got sickle cell traits, and they're at risk of having a child with sickle cell disease. That's because some labs in those parts of the world are not reputable.
So we need funding to develop those labs to put standards whereby we can get tests that are accurate for the children within that, and the pregnant mothers within that population.
Because there's nothing more distressing for me than going to visit a mother and explaining to her your child has got sickle cell disease, and she said, and we planned to have an appointment to come find me for counselling, but she didn't bother to come because she said she already knew she'd been tested back home. She's AA, so she didn't bother to answer our call until the child is born.
But could it be that the prevalence is so overwhelming, sickle cell trait, AS, hemoglobin A, is so overwhelming in Nigeria that if you're AS, you're fine. That's the kind of conclusion, and it's easy to say that. Whereas in the UK, AS is not as common.
But it has genetic implications.
Yeah.
You see, a lot of people go back home, for example, they go to be tested to see whether they've got sickle cell disease.
Yeah.
So obviously the lab will say to them, you're okay, you have got sickle cell disease. But they will not say, but however, you have sickle cell traits, which has genetic implications for your children.
So what you're saying is sickle cell trait matters as well. And people have to sit up and take notice as well. Because once you partner with a person with sickle cell trait, as well, you have a 1 in 4 chance of having a child with sickle cell disease.
And of course, we're not quite like the USA, where when people are getting married, they have blood testings for various things. So the chances are of meeting up and cohabiting with someone that's likely to give you the percentage that your children will be born with this debilitating disease is very high. And what people need to understand is that it leads ultimately to death. Suffering and ultimately to death. So it needs to be taken seriously and given the care and concern that it rightly deserves.
It leads to death. At the same time, though, if people pick up and take notice of the management that's available, the care that's available, then life can be prolonged much longer than historically it was able to be.
I mean, certainly, I mean, the quote that's often the quote that they usually make is they say, oh, on average, the average lifespan, when they talk about average lifespan. And we tend not to make too much of that average lifespan quotation. We know that obviously if you have a chronic illness, that's going to be, any chronic illness that's going to be causing you pain, that's going to cause organ damage over the years, inevitably the lifespan will be reduced. But what I'm saying is, in as much as the lifespan may be reduced, there's a lot that can be done to prolong the lifespan. We've got patients on my caseload who are in their 70s. They've got sickle cell disease. Are you with me? Yeah, they've got. In fact, one of my colleagues, her grandmother came here on holidays, and that's the first she knew she had sickle cell disease because she was ill, and they took her to the local hospital. And this woman was in her 70s. She'd grown up in Jamaica all her life not knowing she had sickle cell disease, until we then labeled her and told her she had sickle cell disease. She was perfectly healthy.
So then what would someone need to do now that they've been diagnosed with this debilitating disease?
The important thing is for them, one, to understand what the condition is.
Yes.
Secondly, what it does within their body. Thirdly, how to look after themselves. But more importantly, how to avoid the things that can trigger illness.
And what can they do?
So, for example, they must make sure they drink lots of water. Yeah, we usually say, for an adult, they must drink at least 3